kick off Rehab Week, I'd like to welcome Stacy Christensen. She is a board-certified clinical specialist in neurological physical therapy and an assistant professor at the University of Nebraska Medical Center. Stacy will be speaking with us about recognizing and treating Pusher syndrome in post-stroke rehab. So I'll let her get started, and then we'll wait for questions at the end, all right?
Okay, I'm most excited to take that mask off. So welcome, you guys. As she mentioned, I'm Stacy Christensen. I'll take a couple of minutes and tell you about myself, and then we'll just kind of jump into the topic a little bit. So if you really like to read, this is a little bit about me. I graduated from the Med Center back in '08. I jumped right into Good Samaritan Hospital in Kearney, where I worked a little bit on acute care, and then transitioned pretty quickly to inpatient rehab, which I understand is most of you guys. I did took a lot of students for their rotations in Clin Ed while I was there. My passion is rehab after stroke, and I am really intrigued by Pusher syndrome. I was when I was a student, and then I experienced it a lot more when I got into the clinic than I thought I would, and so I'm excited to share with a little bit of it with you. Another thing about me is I tend to talk really fast, and it's not necessarily because I'm trying to get through everything. I just talk really fast. So if I'm going too fast and you need me to slow down, just let me know. I do not have any disclosures or conflict of interest to share with you today. And so this is where we're going to start. We're going to talk a little bit about what Pusher syndrome looks like and being able to recognize the characteristics, the basic science behind what's happening to these patients that's causing it, give you some treatment ideas and strategies for what to do with the patients, and then be able to translate all of that information. So before I jump in any further, I just want to get a little bit of a gauge for who's in the room. So how many of you are PT, OT that I'm talking to today? Okay, that's kind of what I had anticipated. How about speech therapy? I will try to relate a little bit of this to you guys, but probably not as much. And then any other ancillary, social work, administration, anything like that? Social work. Okay, so I would imagine this will apply more to PT and OT, but if I have some way to give you guys a little bit of encouragement along the way, I will try to throw that in there. So what is Pusher syndrome? It's a postural control disorder. It tends to be the result of a unilateral lesion in one hemisphere or the other. They tend to push themselves toward their weaker side. Using their stronger limbs, they push themselves over. You can see the gentleman here in the photo doing that. It causes some instability, as you can imagine, which increases their fall risk. So one more question for you guys. How many of you have seen Pusher syndrome? You know what I'm talking about? Perfect. How many of you are comfortable treating it? Perfect. So you guys can join in and help me along the way. Most of you already know that there are several other names for Pusher syndrome: ipsilateral pushing, controversive pushing, pushing behavior. The one I want to talk a little bit about is lateral pulsion. So it is still used in the literature to describe pushing behavior, is lateral pulsion, but it is often used to describe lateral medullary syndrome or Wallenberg syndrome. And so if you're reading in the literature and you come across that term, just take a minute and make sure what they're talking about, because they differ in the direction of their pushing. So that's just my little disclaimer there. I tend to refer to it as pushing behavior, just because it's not known as much of a syndrome as it once was, and we'll get to that. So those key characteristics, I talked about them all a little bit already, is they're using their stronger limbs to push toward that hemiparetic or weaker side. There's usually that pretty typical abduction and extension of those limbs. They get it kind of quite a ways out there to the side to start pushing themselves. And one of the key characteristics is they will resist your attempt to bring them back to midline. And so the more you push, the more they push, and you're all nodding because you've all experienced it. And you can get a really good workout trying to treat these patients sometimes. They do often demonstrate that decreased awareness of midline. They tend to demonstrate a correct head orientation. So in the pictures I showed you, that guy's head was off to the side, but oftentimes their head is still upright, but they're pushed off to the side. And so again, you guys are nodding, you've seen it all before. And they're afraid of falling, but it's toward the strong side. So I keep referring to my right side as my strong side, and the reason they push back is when you try to push them that way, they think they're falling, and so they push back against you. And so just another picture, and again, if you guys have seen it, it makes me wonder if this guy really does have pushing, because his head is off with his trunk, but I would expect it to be a little bit more upright. With her helping him there and standing, if she was just standing still, acting like a wall, and he was leaning on her, they would probably be just fine, but the more she started pushing into him to get him back up, the more he would start pushing. And it gets to be a little bit of a wrestling match. I can't see the chat, so I think they're going to bring all the questions to me at the end. But if you guys in here have any questions or comments along the way, please feel free. So incidence varies all the way in the literature from 9.4 all the way up to 63%, which is a really wide range, and it has to do with the inclusion criteria that they used in their study. Daniels used a really low threshold for his inclusion criteria in his study, which is why his numbers are so high. The most recent of those is about 17%, give or take. I'd say that's about what I see, maybe a hair more, especially in inpatient rehab, because the patients that come to rehab are usually a little bit more impaired than the ones who go home. What would you guys say? Does that seem about accurate for what you're seeing? About 17% or so? Yeah, getting a few nods. Perfect. Okay. Just to jump into the background a little bit, it was first described in 1985 by Patricia Davies. She had treated some patients and felt like she was finding this trend of all of these symptoms that fit together. The left hemiplegia, because she said that it only happened in right-sided lesions, and so they had to have left hemiplegia. They presented with that pushing that we've already talked about. She said they always had spatial and sensory neglect of that left side, that it was present in all individuals regardless if they had this pushing behavior, and then they had that shift toward the side with no attempts to correct, and they resisted the attempts to help them correct. So she pulled it all together and said they have all of these things. This is pusher syndrome. So as healthcare in general has transitioned toward more research-based information, right? We don't just necessarily go with, well, so-and-so said it was this, right? We start digging into what the literature really tells us. And so clear back in 1996, they kind of started trying to figure out, is this really what she said it was? What's happening? And so Peterson looked to see, he looked at 647 stroke patients over the course of a year. And what he found was that it was pretty even, actually. So you can see there's a little bit of a mismatch there, but he said that the patients who had pushing behavior were about half and half right brain lesion to left brain lesion. And then in 2005, their studies looked at 114 patients and found a significantly higher prevalence in right brain, but that it does still happen in left brain lesions. And then again in 2012, something similar. He looked at 1,660 patients and again found that 9.5 versus 17.4% of all of the stroke patients had pushing behavior. So it does still show that it's more prominent in patients with a right brain lesion, but it does happen. And about half as often, I would say, in those left brain lesions. So we can see it either way. And then how do the other characteristics fit in? These two studies here show us that they don't have to be present, right? They're often highly correlated. They often do present with some sort of either sensory or visual neglect of that side, but that it doesn't have to be there. Sometimes it's just the motor piece. And so they are correlated, but that's why they've stopped necessarily calling it a syndrome, because they can tend to have pieces and parts of those characteristics without necessarily having to have all of them. I told you I talk really fast, so apologies. So then the next question was, is it really in the parietal lobe? It was originally thought that this behavior stemmed from the parietal lobe lesions because the parietal lobe helps to process and integrate all of that sensory information. So they decided to see, really, is that true? And back in 1996, when Peterson was looking at it, he looked at the area where the lesions were in patients with and without pusher behavior, and all he came up with at the end is that it's not necessarily parietal lobe, and it seems like the internal capsule is involved somehow. And so his takeaway message is that damage of these sensory pathways is involved in producing these symptoms somehow. That was his total takeaway. And then several years later, Carnath and his colleagues, we'll talk about him a lot today, again went on to say that the parietal lobe is not the cause. He overlaid the images of 23 patients with pushing behavior and looked at it and said, oh, look, that's the thalamus, more specifically the posterior lateral thalamus. And so it's not the parietal lobe at all, but it has more to do with this sensory integration happening at the internal capsule in the thalamus. Did you have a question for me? No? Okay. Okay, so what causes it, right? It's happening in the thalamus. These systems here, you guys all know, is what helps us to maintain our balance and our upright postural alignment. All of these things are involved. But the literature shown here goes on to tell us that it's not the vestibular system at all. It does not play a role at all. And that it's not just a somatosensory loss problem, which we already knew. So Carnath, in that study in 2000, took 5 patients and he put them in a padded chair with free-floating legs, and he rotated them in the frontal plane with their eyes shut and had them tell him what their perceived postural vertical was, and they were about 18 degrees off from earth vertical in the direction of the lesion. They also discovered that their visual vertical remains intact, and so we'll talk about that in a little bit. Their perception of upright in relation to gravity is what's really affected, and they're getting this mismatch of information between their visual system and their postural system. And then Perrineau went on to tell us later, he coined the term graviceptional neglect. And he said what's really happening is there's an extinction of those signals from the trunk and pelvis on that affected side. So that's really what's giving them this mismatch of information. So this one just talks a little bit about what it is not, right? So you guys have probably seen all of these things before. In some way or another, they're related with some of the similar symptoms, but just helps you differentiate. If you feel like you're seeing some of these factors but you can't really tell, this might help you to differentiate a little bit. And then here is that Wallenberg syndrome that I talked about, and the major difference there is they push toward the site of the lesion compared to those with pushing behavior push away from the site of the lesion. So we're going to transition just a little bit to talk about some of the outcome measures that exist to help recognize the presence of pushing behavior, help grade it, and then track progress over time. And so there are really 3 scales that we can use to help track progress. The first one is Scale for Controversive Pushing. It was inspired by Carnath and based on Davies' original principles presented in that book. Later, a modified Scale for Controversive Pushing, just modified a little bit, a little more extensive, both in the testing parameters and in the scale that they use. And then finally, the Burke Lateral Pulsion Scale. A few more measures still. There's the 17-point scale. And it's the only scale to incorporate rolling and walking. And so what I didn't talk about early on is that pushing behavior can occur in any position. We tend to notice it in sitting. That's when we first start to go, oh, something's happening here. But it could be so severe that it's presenting in that supine position. I don't know if any of you guys have seen it. I've seen it once or twice in acute care. And they're really kind of even trying to push themselves over when they're in bed. And then sometimes it's more mild and we don't notice it till we get them up on their feet and they start walking and we're like, oh, there it is. So it can happen in any position, and this scale's the only one that incorporates both of those activities. The other thing that I meant to mention early on and missed it was that this is often identified first by nurses and therapists because we're the ones that are really getting them moving, the ones that are helping them get up for the first time, spending the most one-on-one time with the patients. And so we get them up to move them, and we're like, oh my goodness, they have pushers. And nobody's noticed it yet, even though they've been in the hospital for how many days, because they haven't really been moved very much. Okay, so here's an image. Hopefully you guys can all see that well, the Scale for Controversive Pushing. And so all of these, have you guys seen these scales? Do you use them? No. Okay. So they're actually pretty useful, and I'll share a little bit of all 3 of them with you. But this first one is done in sitting and in standing, and it uses those 3 characteristics from Davies. So spontaneous body posture, how do they sit just at rest? The use of those stronger limbs to push themselves over, and then resistance to being brought back to midline. And you can see the scale's a little bit interesting. It's 0 to 1 with kind of some increments in the middle. And the originally suggested cut score for this scale was they had to have a 1 in all 3 categories. So the top score in all 3 categories to be considered pushing behavior or pusher syndrome, which I find to be interesting. The modified Scale for Controversive Pushing, I would say, is not used near as often. I've actually looked for an image extensively to share with you guys, and I couldn't even find it. But it does include both sitting and standing, but then it also includes that sitting transfer and the standing transfer, which you guys have moved these patients. Sometimes that's when we really start to see it. So that pulled those in, and then it has a little bit wider scale that goes from 0 to 2 for a total of 8, and they use 3 or more as a cut score for having pushing behavior. I don't know why I had you print my notes, because I've not been following along at all. And then finally is the Burke Lateral Pulsion Scale. And you might be able to read it well enough up there, but it's pretty tiny. I went ahead and gave you the link in case you guys want to look it up, because I find it to be pretty useful. But it incorporates a log roll, so for those more severe patients, sitting, standing, stand pivot, squat pivot, and a scoot transfer, and then walking. So quite a few more measures. And then it uses a cut score of 2 or more to identify pushing behavior. And so I do have an example here. I won't read it to you because I think you guys might actually be able to read that, not in slide format. But it really is prescriptive of what you say to the patients, what you have them do, the position that they're in, and then how to score it. And so we'll talk more about this scale as we go on. And so it doesn't do any good to have outcome measures if you don't know which one you should use, right? That happens a lot. There's a whole bunch of them. We have no idea which one to pick. And so they've done quite a bit of research on which one is the best. And so the original study that I was able to find, he looked at scale for contraversive pushing and found that it had good reliability. The internal consistency was really high, and went ahead and said, yes, use this. It's a good scale. Move forward. But he said we should use a cut score of more than 0 in all 3 categories instead of a cut score of 1. So instead of saying they have to have the worst, most severe behaviors in every category, they're saying you present with some positive behaviors in every category, and let's call that positive. So he just changed the cut score but said go ahead and use it. Then there was a systematic review a little while later that kind of looked at all 3 of them but didn't necessarily compare them, and he said they're all reliable, they're all good, use them all in the clinic, they're worth using. More specifically, they compared the scale for contraversive pushing to the Burke lateral pulsion scale and found out that they have moderate agreement, as they should, but that the Burke lateral pulsion scale has higher sensitivity but lower specificity. It's more responsive to small changes, which I think in inpatient rehab is what we're looking for, right? We need to be able to track that progress. And then it allows us to grade that severity of pushing behavior over time so we can show outcomes. You guys have all treated these, or a lot of you have treated these patients. Sometimes it's hard to show progress because it's so slow and you just don't get those huge functional leaps, especially early on. So being able to show that we are making some difference and they are getting some improvement is useful. So he said that the Burke lateral pulsion scale was better. And then there was an updated systematic review in 2017, and they used that Cosman checklist, which basically just helps study the methodological quality of each one of the studies to see if it was a good quality study when looking at outcome measures. And basically they were all poor because the sample size is so small. There's not enough studies on contraversive pushing or pushing behavior. So the sample sizes are all so small that they all got a rating of poor. But the Burke lateral pulsion scale, when identifying pushing behavior, was the only one that scored above poor, which is still not good, but at least it's the best of what we've got. So my takeaway from that is that it's the most likely to detect those small changes. That's the one that when I'm in clinic, I personally use. But there are a lot of options, and I think sometimes it just depends on the time that you have to use that measure, right? And then finally, there was a recent one in 2018 where he looked at the Burke lateral pulsion scale compared to Tinetti-POMA. Do you guys use that much still here, the Tinetti? I don't use it as much anymore. The psychometric properties of it just aren't quite as good as some of the others. So it is still used, just I'd say not quite as often. So I found it interesting that that was the test he decided to see if it related to. But he did find this moderate negative correlation, which we would expect, right? The lower their Burke lateral pulsion score, so the less pushing behavior had, the better their balance. Not surprising. It measures what it's supposed to measure. The scales correlate the way that they should. But he suggested using a cut score of 3 or more. And I forgot to tell you that on that Burke lateral pulsion scale slide, the recommended cut score is 2 or more total, demonstrates pushing behavior. And he suggested that we change it to 3 or more, that it better related to their actual ability to recognize vertical and that resistance to pushing behavior. And then his last takeaway was that we need larger studies because we can't really see how good the tests are until we have a big enough N to start to compare them. So this is the fun part, treatment. What do we get to do about it? And I'm guessing, based on the familiarity with you guys in here, you're already doing a lot of these things, but maybe I can give you something new and some new tricks that you can try. But what Carnath found in that study, you should recognize the picture on the left, is that their visual vertical remains intact. So in that same study, where they had them rotate in that chair, he then had them open their eyes. And their vertical improved to less than 1 degree from earth vertical. So their visual vertical remains intact. So if we cue them to use their visual environment to correct their alignment, they can do it. The thing is that they often won't do it spontaneously, and we have to cue them and help them recognize that mismatch. So Carnath and Bratz, they came together and decided to try to develop a plan of care to treat some of these individuals. And so their goal was to help these patients recognize that their altered posture and their perception of erect posture was giving them a mismatch of information, right? So everything I just talked to you about, the things that we know, Let's tell the patients that and help them to understand that that's what's happening to them. Then help them learn whatever movements are required to learn how to get to vertical, and then help them maintain that position long enough to do functional tasks, which I'm guessing is what all of you guys are doing, right? Let's get there, and then let's figure out how we can do something while we're there. And then he went on to say that it should not be treated in a horizontal position. We need to get them up, sitting, standing, walking, moving, in order to get the system really to start working and learning, because we're not going to make these patients in particular better doing quad sets and straight leg raises, right? They need to move. When these guys are talking about learning how to do movements that require them to reach that vertical posture, they started recommending that these patients reach toward their sound side. Let's get them reaching toward that sound side. It'll bring them to earth vertical and then beyond so that they have an easier time getting there. The next study agreed that we need to start using those vertical cues and prompting them to find verticality, but they said we should reach toward the hemiparetic side. Get them weight bearing through those limbs, reaching over there, moving in that direction further. They also recommended body weight support treadmill training. I'll pause for a minute, give you my 2 cents. When I have patients reach toward their hemiparetic side, they just seem to get stuck over there. So my personal thing, I always work toward that stronger side, and you're all agreeing with me. It's usually easier to get them to move over past midline and then come back to center, and then you can start working from there. I've not personally had great luck having them reach toward that hemiparetic side, even if we are weight bearing, because then they're just really comfortable over there and they'll just hang out. And it's really hard to get them to come back to upright. And body weight support treadmill training with this population is a little bit difficult. In my personal opinion, it seems to bring out those pushing behaviors. And so by the time I get my patient on the treadmill and moving, I'm either out of time or they're so exhausted that we can't do anything more. And so I personally haven't had great luck with it, but they did it and they liked it. We'll talk a little bit more about that down the road. And then in 2015, Yang and his colleagues decided to use computer-generated interactive feedback. So we've talked a lot about using that visual vertical, finding your environment, right? Whether it's a window frame or a door frame, a mirror is something that's used very commonly, right? Figure out where you're at, find that. So he decided, let's use this computer-generated interactive feedback instead of a mirror and see what happens. So it was basically like virtual reality circa 2015. And it was a Wii Balance board that was customized slightly so that they could start to get this virtual reality. And what he found was that they got better faster. In his study that worked really well, it produced significantly better outcomes than just the mirror training. Do you guys have an option for virtual reality here? I don't. You have a Wii? We have a Wii also. It just doesn't have the cool virtual reality component. And so I've not done much with that. But if you do get the option and you can talk somebody into buying you some virtual reality, there's your nudge. So then this is the piece that I really like to talk about, really because it hit home for me, and this was what I had figured out worked for my patients. So in 2017, Pardo and Galen did a presentation at CSM, which was a 5-patient case series that really just presented what they had figured out worked for them. It started off with just what they could find in the literature and then their personal experiences and said, this is what we find is working for us, and so we're going to share it with you. It has since been published as a 5-patient case series in 2019 and can be found, but they focused on functional activity, right? The what we do every day in inpatient rehab, transfers, being able to propel themselves in their wheelchair, basic balance in sitting and standing, be able to obtain it statically and then dynamically, and move from there, which I feel like relates to anybody who's ever worked in rehab because that's really what we do. So this will likely not catch too many of you by surprise, but what they suggested when starting out those transfers is to start with those lower level squat, pivot, or scoot transfers. Even if they're not pushing a lot and sitting, you start moving toward that standing position, the pushing kicks in. So let's start in those lower level transfers and just get them moving. And let's look to and move to that hemiparetic side to start with. Have you guys all started doing that, or at least a lot of the time? If you've all been there before, they grab hold of something with that strong arm, and they either push themselves away from the direction you're trying to go, or they will not let go for dear life, and you're working so hard you can't figure out why you're not going anywhere because they won't let go of that chair. And so they suggested moving toward the hemiparetic side because they're already pushing that way anyway, right? So make it easier on you and them. And then you can have them hold that hemiparetic arm with their stronger arm because then they can't push. And so it's tucked in, and then you can just deal a little bit with the pushing in the leg, and hopefully that will help you get to the chair. And I've taught that to a lot of the nurses on our floor because they're trying to figure out how to move these patients. We don't want them in the lift. So we're teaching the opposite of what everybody's ever learned, which is transfer to the strong side, and let's go toward that weaker side because we'll all have a lot more fun. And then for wheelchair mobility and positioning, it really boils back to alignment. So find some sort of a custom chair if you can, or modify the chair that you have to try to get them in that upright alignment. Especially for speech therapy, they'll love you if you can get them upright. But even when they're trying to propel their chair, if you can start with a position that makes it harder for them to push, you might be able to keep them upright long enough to at least go somewhere instead of spinning in circles because they're sliding out of their chair. Right? We've all seen it. So it's really about alignment and then allowing them to make the errors, right? Allow them to run into something and have to scan over there and figure out what's wrong so they can correct it, rather than just giving them the physical assist to go around it. I like that you guys are nodding. It means you're all doing this. And then sitting balance, start with static balance and work to dynamic. That's not rocket science, but if we can't figure out how to just sit there, we definitely can't do anything while we're there. Let's get some static balance first. They relied a lot on the use of a mirror. So while the other studies are talking about this virtual reality, they just said, let's go to a mirror. Give them verbal, tactile cues as much as possible, but really letting them fix it because that's what's going to help them learn. And then their goal was, not surprisingly, achieve midline, then stay there, and then start moving out of it and coming back to it in either direction. So these are some pictures from their presentation at CSM. I tend to, and I would imagine some of you guys have decided along the way too, this is the one patient population where I sit on their sound side instead of their hemiparetic side, because then they'll come to you and they're less afraid of falling if you can give them that sense of stability that they're not going to fall over because you're there, right? We also have to make whatever accommodations are necessary to make sure they don't fall the other way, having somebody else nearby. But I sit on their sound side to give them that sense of stability to weight shift for you. They show using a ball or anything that's mobile under that strong arm. So this patient is supposed to be a left hemi. She doesn't push very much for someone with pushing behavior. But doing anything that makes that strong arm less stable. So a ball underneath there, keeping it in the lap. If you're sitting over there, you can put it on your leg so you can start to feel when they're pushing into you. And then start to reach toward that stronger side. And so they're doing a really complex task. They're right, reaching out in midair and grabbing. You can start with sliding. A lot of time I've gone into elbow props on that side with something high and then drop it down so that they can start to come over there a little further and build up that security because they're just terrified of going over there. And so if you can just make it in small increments where they go over there more slowly and of their own doing, it tends to work pretty well to get them out of that pushing behavior. I lost my things covering their face on that slide. And then you translate that same thing to forward and backward weight shifts. And part of the reason for that is backwards is sometimes difficult, but when they come into that forward weight shift, it starts to mimic sit to stand. And then you'll start to get some of that pushing behavior. So start working on that AP weight shift in sitting, and maybe even some early movement towards sit to stand so that you can start to move past that pushing behavior during that movement before you come all the way up into stands. And then as far as sit to stands go, they're talking about starting from an elevated surface, right? So an elevated mat table, maybe from their recliner instead of their chair, because the less work they have to do, the less likely they are to start pushing. So make it easy to start with and then just work on that static balance while you're up there. If you are working from a wheelchair, right, it's a little bit lower, what they recommend is using an elevated mat on their sound side and having that just to the side of them. And you can do it at a wall as well, but what they recommend is if you use that elevated mat, you can cue them to bring their hip to the wall, because I don't know if you guys are like me, you get them near a wall and you say, put your shoulder on the wall, and they do this, right? Because then they still feel better that their hip is over there and now they're doing this banana thing. And so if you've got a mat table, you can tell them to put their hip on the wall, and you'll tend to get a more upright posture than if you just cue them for their shoulder. And so the elevated mat is pretty useful in doing that. And then in standing balance, same as sitting, right? Start static, make it more complex, give them the cues, and then work through the sequence of achieving, maintaining, and then moving out of and regaining midline. And so here's their pictures of what they were doing. Are you guys doing something similar to this right now? Or some of you figured out that this works? If you haven't, give it a shot. I really, this is what I've adapted to over the years, and this is pretty much exactly what I'm doing. So here's an image of that standing at the mat table. The one thing I've noticed is if you have all this free floating space underneath the mat table, that foot will start creeping out there. and they can start pushing anyway. So if I am using a mat table, a lot of times I'll fill in that space with boxes or whatever I can get underneath there. Sometimes I can position myself strategically to put my other foot over there so they can't get it out of alignment. But I have noticed that with the mat table. If they're real sneaky, they'll start creeping that foot out there. And some of them are really good. Like, they don't shove it out there. It like inchworms out there. So then they're pushing, and then you don't know how it got there. And then if that's just too difficult or you need some more security, they're terrified of falling. Because at the mat table, if they're really afraid of falling, especially if they've fallen since they've been in the hospital, they've got all this free floating space by their shoulder. And sometimes that's really scary. So you can go to a wall. Gives you a little bit more security. I do this a lot, and then I'll put a mat table in front of them and have them work on reaching and moving, or not a mat table, a bedside table, yes. And have them start doing activities from there, so that way you can start to incorporate some functional tasks and upright balance. And I often walk along that wall for the first few times because it'll give them a prompt for what's on that side. They feel safe, and you can move in a forward direction with a little less arms flailing to keep things contained. And then a final option that they suggested was to put somebody back in a corner, because then they've got stability on both sides. They're getting cues from their hips and their shoulders. You can block the knee or the chest and really give a lot more cueing if you want to. I personally have a really hard time getting a patient who's pushing and needs that much stability in that position. Getting them out of a chair into a corner and wrangling them by myself is much harder than just doing it at a wall and getting extra people. So that's my personal experience. If they need that amount of support, I usually can't get them there good enough on my own to even do that. But it is an option, and so sometimes you're going to find that one patient that it works for, and you're going to remember it, and it will work. So their goals of this whole thing, again, they used 5 patients, and their goals for each of those 5 patients by the end was to be able to sit unsupported in midline for a whole minute without assistance, transfer bed to chair, chair to bed by themselves with min assist, and then decrease that scale for controversive pushing score down to 3 or less. And they, they achieved that goal in scale for controversive pushing and their FIM scores, which we don't use anymore, but most of you should know it, and if you don't, it's very similar to GG. And so those scores improved in all of those patients, and 80%, or 4 out of 5 of them, were able to sit unsupported for a minute at the end. And if I recall, the one who couldn't do it, it was more cognitive related. They were too impulsive, and so they couldn't get him to stand there or sit there without supervision. And so that patient was physically able to do it also, but cognitively wasn't safe to be left there. So their end result was all of these things that we did. They worked. Try them. Use them. I use them a lot too, which is why I really fell in love with that article. Okay, I promise we're getting toward the end. You guys probably have to get back to patient care. No? Not yet? Perfect. Okay, so there was a literature review done in 2019, and they looked at all of the articles that were produced on treating pushers' behavior, and the first of those used the Lokomat on these patients. So they said that robot-assisted gait training was better than traditional PT. And so they did it 5 days a week for 2 weeks, basically the amount of time that they were in inpatient rehab probably, and they found that the reduction in pushing behavior was greater than in the standard PT group. So they said robotic-assisted gait training works. Another study didn't specify what type of robotic gait training they used, but again, they got better improvements in their Burke lateral pulsion scale, Berg, and PASS compared to traditional PT. And so according to those 2 things, robot-assisted gait training is pretty great. There was another one that did a case report on body weight support treadmill training. I couldn't find the specifics on this one. I'm actually really interested in if he was outpatient or inpatient, because being efficient with that in inpatient seems really difficult to me. But they did find good results. The patient had decreased pushing behavior and improved function at the end of his 15 days of treatment. And then again, looking at visual feedback, we talked about this study by Yang a little bit ago, but basically the result was that computer-generated had better improvements in pushing behavior than use of a mirror only. And then there was a case series, I think it was 3 patients, again, where they used just a mirror, just any sort of visual feedback, and it said that they had significant improvements in that score. So that's not too surprising. And there's another one called galvanic vestibular stimulation that they do prior to PT. They give them this galvanic stim. The bottom study here was a case series, and basically it showed that there was no change. They were giving 20 minutes of treatment and then going to PT, but it didn't help, so they quit doing it. And then Kruer compared those 3 interventions together. So galvanic stim, to robot-assisted gait training to standard PT. And overall, there was no significant difference between their interventions, except robot-assisted gait training improved those Burke lateral pulsion scores compared to the visual feedback, or PT. So I feel like that should be pretty excited for you guys, because I feel like you're getting some robot-assisted gait training, or you have it here already. It's here already, and some of you are being trained on that. So if you've got patients with pusher's behavior and they seem appropriate to get fitted in that machine, you might be able to get some better results using that than something else, especially if they're a tougher patient and you're having trouble finding what will work. That might be a nice option to implement for those patients. What does it mean? Clinically, how do we integrate all of this information? Clear back in 1996, when they were looking at this, Peterson told us that the patients were able to reach the same functional outcomes over time, but it took them 3.6 weeks longer to get there. And you guys have probably seen that. It takes them a lot longer to get better. Well, here's a number. It takes you about 3.6 weeks longer to get to that same functional level. So overall, he said it didn't affect that end result. It just took a long time. And it increased their length of stay by 29 days. Not it was a 29-day stay, but it increased their stay by 29 days. I don't know about you guys, but a 29-day stay is pretty hard to come by nowadays, and that was increased from whatever they had to start with. So that's a lot of therapy to get to those end functional goals. If we think about that a little bit more, it goes on to tell us that if the damage was done in the right cerebral hemisphere, the results were slower than if it was in the left cerebral hemisphere. And so we need to consider laterality of the lesion when we're trying to figure out what we can do with these patients, right? Goal setting, discharge planning, all of those things that happen much quicker than 29 days. And then here, this one is interesting for you. In 2013, they found out if the length of stay in rehab was exactly the same, our interventions were half as effective and half as efficient if we got the same amount of time. So if we are getting the same amount of time, which tends to be the trend right now, we're getting X number of days in our CMG, we're only going to be half as effective on these patients. So that helps us early on to start educating the patient, educating the family on expectations, discharge planning early on. And that doesn't mean we can't get them better and we still have to give them hope, but it helps us, I think, to be a little bit more aware of, I'm probably not going to tell you you're going home at the end of these 3 weeks with your family unless they're able to provide 24-hour caregivers and all of this safety things in place. So that doesn't mean we should take away all of their hope, because the research shows that they can get better. It's just going to take longer. And then the longer the pushing behavior persists, the worse their rehab outcome. And my personal little takeaway from that is it's probably because as you leave inpatient rehab, home health, outpatient, whatever it is, skilled nursing, the amount of therapy tends to trickle down, right? And so if they need this intensive amount of therapy and they're progressively getting less of it, the longer their symptoms persist, the longer it takes for them to get better, the harder that eventual rehab outcome is. So it doesn't mean they can't get there, but we've really got to be doing a lot of education and encouraging them to advocate for themselves and be active in their rehab and asking for more regardless of where they're at, because they need more. And maybe they just need to be doing it on their own or with their family. And then in 2015, this retrospective chart analysis, which if I flip about 40 pages forward in my notes, I could tell you how many charts they looked at. But they looked at whether or not they had just motor impairment, if they had motor impairment plus proprioceptive or neglect impairments, and then the last group was if they had all three of those things. And what they found out after 27 days of inpatient rehab, which again is still a little bit long for what we're seeing now, if they only had motor impairments, they had a 90.5% chance of reaching those functional goals. But if you throw in motor impairment plus proprioceptive or neglect issues, that dropped all the way down to less than 60, and if they had all three, it dropped all the way down to 37%. So we have to take into account the presence of that proprioception and neglect issue on top of that pushing behavior. And again, he went on to tell us that if it was a right brain lesion, they had a harder time reaching their goal than if it was a left brain lesion. And then another study that told us that we should consider older age, the age of the individual at the time, the severity of their impairments, which is not super surprising. And so he just told us to take all of those things into account, plus he said FIM cognition. Again, FIM is gone, but we still assess cognition. Their ability to recognize what we're telling them about their visual vertical and the mismatch of information. If they don't have the cognition to understand what we're telling them, it's going to be a lot harder to help them work through it, right? Overall, it's fairly common as 63%, considering the source as far as how often it's happening in our stroke population, There are some really clear identifying factors to help us recognize if it's present, outcome measures that you can use to track your progress over time. Some really great treatment ideas. Hopefully I gave you some new ones today that you maybe weren't familiar with, or ones that you could use before, or at least reaffirmed what you have been doing. And then really what to think about when you're making that plan of care and helping you to be able to grade where you're setting your goals, what discharge recommendations you're making for them. And I really think that it's pretty fascinating personally. And then here's my favorite one. You can be your patient's superhero if you can help them to work through pushers. So those are my 3 kids a couple of years ago on Halloween. They're equally as ornery now, just bigger. So I'll open it up to questions. It looked like there's quite a few things in the chat, but I don't know how many of those are just people signing in. So are there any questions from in the room?
I'll let you ask them, and I can check and see if there's any in there.
Okay. Nothing in the chat. I said it all. I said a lot.
When you're looking at the articles that talk about the different factors that slow their rate of progress or change their rehab potential, should anything talk about like patient size or body habitus? I feel like this is one population where if a patient's larger and they have controversy pushing, it's just so difficult.
Yeah. I will say I didn't find anything of it in the literature, but I think that most of us could, with our own experience, kind of deduce how that would play a role. I think it would be interesting to see if they did. Oh, sorry, yeah. So he asked if there was any information in the literature about body habitus or size if they're presenting with pushing behavior as well. And so I did not find anything in the literature. It doesn't mean it's not there. I did not come across it. But I think all of us have tried to work with patients of all sizes with pushing behavior, or many of us. And it's a little bit harder if they're harder to manage, right? If you compare your size to theirs and they're outweighing you, or just a different, even if they're taller than you, right? It's harder to help them get into those positions and challenge them. And so I feel like I could deduce a correlation, but I did not find it in the literature. That's a great question. Yeah?
The other thing I would say in treating these people is that your picture with the mat, where you have them with their hip against the mat, I don't find that to be successful unless I get their elbow bent and I have them weight bear through their elbow, because otherwise putting their hand on that mat, they're going to push like crazy away from that mat. So if you get their elbow planted, then have them tap their hip against the mat, or if they're really bad, I'll just have them stick their hip to the mat.
Mm-hmm.
So then, with the other leg, maybe they can do a toe tap or something. I feel like that helps a lot with pushing behavior. If you get the elbow bent, having the weight bear in the elbow.
Yeah, I absolutely agree. So what she was talking about was if there is a, stop share, if you have somebody where you're trying to get them up on that elevated mat like I was talking about, instead of having them put that hand on the mat down here, she gets the elbow bent and up here because it's harder to push from here than it would be if that elbow was extended. So flexing the elbow, I'm basically talking to the people on the webinar, flexing that elbow because it's harder to push, and then doing that same thing with the hips is tucking it over to the mat, and then incorporating even a lower extremity task with either lower extremity, but bending that elbow, that's a really good point. Thank you. Any other thoughts or questions?
I don't do rehab as much anymore, but the facility I was at before, a lot of times, once if they progress to the point that they're able to walk, instead of having them use a hand walker, they were kind of started, we made our makeshift walker with a wheeled walker with a slide board kind of taped onto it.
Mm-hmm.
So they have both hands
Yep.
in front of them and pushing that way versus, using that strong section where they would tend to run out.
Yes. So for the people online, what she was just talking about is when you progress to gait training, instead of giving them a unilateral device, bilateral is better. And so if they don't have grip with that impaired hand, making something, because as PTs and OTs, that tends to be what we do. We just figured out that she said they tape a slide board across or fix a slide board across the walker so they've got that bilaterality. I've been known to have a bedside table and then have a tech on the back side of it pulling it along or having them push it even with some Dyson under their hands. So yeah, anything like that. If they've got the grip for a walker, that's fantastic. And sometimes I try to get them moving even without a device to start with. If I can get them secure enough up against that wall and you've got a long enough wall to go forward, yeah, I'll try that. It's just walking with no device because then they just can't push. That's a great comment. Thank you. Do you have something, Caitlin?
Do you use BLS as the outcome measure, or do you use the pass more often? I feel like we haven't used BLS, but
I tend to use PASS often. I have used Burke lateral pulsion a couple of times when I had a patient that had the ability, right? It was either workman's comp wouldn't be, right? But like private insurance, where they had the ability to stay on our rehab unit a little bit longer, and I needed the ability to show that small progress over time. I have used it a couple of times so I could track progress because it was so slow. I just needed a win. And so I have used it a couple times, but the PASS is just so easy to try to implement or to at least get some scores on that I do use that pretty often. But of those 3 scales, I'd say I've used Burke lateral pulsion more frequently.
Again, not being in the setting as much anymore, how many people would you say you see that in the long term end up being pretty much independent with walking or, versus just being able to transfer themselves? And
Right.
I know that someone comes in and you're like, oh, I think they'll do pretty well, and then it's just like, what happened? Why are they not?
Yeah, so her question was, in our experience, and I'll open this up to Methodist folks as well, how many of these patients are actually, do we get to see walking and moving independently? I've been out of inpatient rehab mostly teaching for the last couple of years also, but I'd say the ones that I'm able to get to that level in rehab is not a lot. There are a lot of them where I'm like, you're right there, like just keep going. And so I'm either training the family and really just lecturing them to death about like, I need you to keep them walking, I need you to keep them moving, don't let them stop. Or I'm calling their outpatient therapist and I'm like, this is what we've been doing and I really need you to keep doing it. But the amount that I've gotten to that level in inpatient rehab before they had to leave me is pretty small.
And I would agree. And I would say I've found that oftentimes they end up transferring or they don't get, I think people are scared to transfer pressure people, and especially if they don't have the experience, they become a very scary fall risk very
Yes.
fast.
Yes.
So I feel like they resort quickly to like, we're not walking you at all, it's so unsafe.
Right. And so what Caitlin was just saying is that she feels like sometimes when they're transferred off of inpatient rehab, people, therapists, families, other individual nurses are afraid to move them because pushing behavior is so unfamiliar to so many people that risk of falling seems so high that they just quit moving them. And so I've made it a point that if I've got somebody transferring off of rehab, I call that receiving facility, or I make sure that family is in there with more than one family member getting one-on-one training as often as I can, right? You get family dynamics, and sometimes you can't get what you want. And sometimes the receiving facility doesn't call you back. But you do what you can, and you tell that patient, like, when you get there, I want you telling them this, and we're doing this, and this has worked for me, and really advocate for yourself because this is what you need. And then, unfortunately, I don't get to see most of them later. So I don't know. Some of them come in, and they're just walking in, and I'm so excited. But most of them I just don't get to see again. Are there any questions in the chat yet? No? Perfect. Anybody else? Otherwise, it looks like you might get a few minutes. Yeah?
Do you have any thoughts on helping our nursing staff or CNA staff and feeling more comfortable? I feel like sometimes I'll help that CNA, but then a whole other CNA the next day, or just trying to help them know that it goes against what everything we've always taught them is the strong side. If you have any suggestions on that?
I personally, I was a lead therapist on our rehab unit for a number of years when I was there, and I was able to get my director to agree to, a pilot program where as the nursing staff came in and were oriented, they spent some time with me, and I was able to talk them through just some of the basic things that they need to know about transferring and moving people, and I would often just put my little plug in there. Sometimes I'm going to tell you that they need to transfer toward that weaker side if XYZ, and then I write it on the whiteboard in their room because you guys have the same type of communication boards. Her question was, how do we translate this across all disciplines? Because you're right. I don't know if I have any nurses in here today. I forgot to ask that. Sometimes we've got this great grand plan, and then we send them back to the room, and we're gone for 16 hours of the day, and then they're not moving, right? So they're not getting that carryover. And so I personally was doing some one-on-one education with every new CNA, every new nurse, but my program is a little bit smaller than yours. And so I was able to do that. What's that?
We actually do that too.
You do that? Yeah.
So we're doing all that.
And sometimes I would just, when I'd take them back to the room and I'm recommending for the first time that I want this guy doing a slide board, I would have the nurse there, like, why don't you practice this one time? You transfer him back to whatever surface. Okay, and I'd really appreciate if you could pass this on to the night shift because this is new and they're probably going to be less comfortable with it. So if you're able to pass it on and or demonstrate a transfer and really promote them doing it on their own, sometimes you're able to get that carryover, and unfortunately we're not able to control everyone or everything like most of us would like to, so it is what it is. But the more education we can do, the better. Well, a lot of you already knew a lot about this, so I'm glad you came and listened to me anyway, but hopefully it was useful information for you, got something out of it. Caitlin has my email, so if you guys have any questions, she knows how to get a hold of me. It's not hard. It's stacy.christensen@unmc.edu. But yeah, thanks for coming. I'm happy to have you all, and have a good rest of your day. It looks like you've got a few walking around minutes before you have to get back to patient care. Thank you.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.